السلام عليكم. السلام عليكم. نبدأ المحاضرات اليوم. إذا ممكن المحاضرين الإيجاز والالتزام بالوقت. موضوع المحاضرة هاي Tibial Osteotomy for Medial Compartment Osteoarthritis. بروفيسور علي شمسدين من لبنان. تفضل دكتور علي.
يلا start. My talk is about the open merge tibial osteotomy for medial compartment osteoarthritis with very small alignment of the knee. As we all know, tibial osteotomy has been proposed as a conservative treatment for active patients with very small alignment and medial compartment degenerative osteoarthritis. Different modes and types of tibial osteotomy have been described. The most popular one nowadays is the open wedge tibial osteotomy. However, all these types have the same objective of decreasing the load on the medial compartment, and the final goal of the tibial osteotomy would be an overcorrection into a mechanical valgus angle of 3 to 5 degrees, and this to unload the medial compartment. So the indications, according to the SSOS recommendations, the ideal indication for tibial osteotomy is an isolated medial compartment disease. The age of the patient between 40 to 60, BMI less than 25 to 30, high demanding patients, malalignment less than 15 to 20 degrees, metaphyseal varus angle, what we call in the English literature the tibial bone varus angle more than 3 to 5 degrees, full range of motion, a good lateral compartment and patellofemoral compartment, no posterior erosion of the tibial plateau, and a normal condition of the MCL and the LCL, non-smoker. So these are the ideal characteristics of the patient for the tibial osteotomy. The not suited patient for tibial osteotomy is a bicompartmental medial and lateral osteoarthritis, a fixed flexion more than 20 to 25 degrees, obese patients, and a meniscectomy on lateral compartment. The possible indication, which means that it is not a complete contraindication, is a flexion contraction less than 15 to 20 degrees. The age is not really a limitation. A deficit of ACL, PCL, and the PLC. We can do the tibial osteotomy, and a moderate patellofemoral osteoarthritis, and the patients who wish to continue sports practice. So the planning is the key of the success for the tibial osteotomy, and it is based on a good radiographic assessment. What is recommended and what I do in my practice since more than 25 years now are these views. And so an AP view in supine, bipodal stance, unipodal stance, the patellofemoral views, and the lateral view, in order to assess the medial joint space narrowing, the patellofemoral osteoarthritis, and to assess the height of the patella and the posterior tibial slope. Now, in addition to these views, it's very important to do what I think they call in the English literature the scanogram, whole leg standing view, and a prerequisite for a good scanogram is that the patella should be in the center of the knee. This is one of the criteria. Another criteria that the ankle should be joined, and only 1/3 of the femoral head should be behind the tibial plateau, as you can see on this X-ray. Now, on this X-ray, we do the measurement of the angle HKA, which is the angle of the malalignment in the frontal plane. The H is the center of the hip, the K is the center of the knee, and the A is the center of the ankle. In addition to the measurement of the HKA, we should also perform these measurements. The first one is the medial, and is the mechanical medial and lateral distal femoral angle, as you can see the measurements on your right hand. And in addition to this angle, we should also perform the measurement of the mechanical medial proximal tibial angle and the joint line convergence angle, and the assessment of the tibial bone varus angle, as most of the malalignments are in the proximal tibia. Now, how to evaluate the angle of the correction? Many authors suggested evaluating the angle of the correction according to what we call the Fujisawa point. The Fujisawa point is located at 62% from the medial edge of the tibial plateau. It's the point that you see on the right hand and the left hand, the F point, and then we draw a line from the center of the hip to the point of the Fujisawa, and from the center of the angle to the same point, and the angle HFA will be the angle of the correction. However, and the goal is to bring the point A to the position A2 in order to make on one line the 3 points HFA or new A, yani A2. However, some authors suggested a more individualized approach to determine the degree of the correction according to the underlying pathology, and so this is what I call the modified the modified Fujisawa point. So for the patients who have only what we call a medial overload without osteoarthritis, the point of Fujisawa would be in the green zone. So from 50 to 55% from the medial edge of the tibial plateau. For the patients who have mild osteoarthritis in the blue zone, between 55 to 60% from the medial edge of the tibial plateau, and for the patient with moderate to severe osteoarthritis in the red zone, 60 to 65% from the medial edge of the tibial plateau. However, based on more than 500 cases, some authors, Stobli, for example, recommended some overcorrection of the varus deformity, but not more than 5 degrees and not beyond the Fujisawa point. So it should be between 60 to 65% maximum overcorrection. Now, the angle of the correction will be the angle of the apex of the triangle of the opening wedge osteotomy, and the size of the medial cortex opening, which is the base of the triangle, will be transformed into millimeters during the surgery. Now, approximately, roughly, 1 degree corresponds to 1 millimeter of open wedge high tibial osteotomy. However, for a more precise angle of correction, the amount of millimeter depends on the width of the tibia at the site of the osteotomy. And what I do usually is the French table. I use the French table of Philippe Ernigoux, which is a table that he published for the determination of the wedge size for each angle of correction according to the width of the tibia. So, if we take an example for a correction of 16 degrees, if the width of the tibia is 50 millimeters, so the opening will be a 14 millimeter. For a width of the tibia for the same angle of correction, 16 degrees, the opening would be 18 millimeter, and for a width of 75 millimeter, the opening would be 21 millimeter. So it's not really 1 millimeter for 1 degree, and so the site of the osteotomy is is about 3 to 4 centimeters from the joint line, and this should be reproduced during the surgery, as we will see later. Now, the site of the osteotomy is usually the proximal tibia, according to the most common cause of the deformity, which is a tibial bone varus angle more than 3 to 5 degrees. However, Lin et al. Suggested two types of varus malalignment according to the presence of the varus in the proximal tibia or in the distal femur. Now, for Saragaglia, who is a close friend of mine, the level of osteotomy is determined according to the measurement of the two angles, the medial distal femoral angle and the medial proximal tibial angle. So according to these two angles, we will have three scenarios. The first one is a normal valgus of the distal femur with a varus of the proximal tibia. You have here an example of enemal alignment with 8 degrees of varus. So the best indication would be a high tibial osteotomy, open wedge high tibial osteotomy, as you can see here. Now, the second scenario, when we have a varus of the distal femur and no varus of the proximal tibia, and this is a very rare situation. It's not very frequent. So the best way to make the correction is what we call a closed wedge distal femur osteotomy, lateral. Here you have an example from my friend Dominique Saragaglia, and so it was the correction was made for this varus of 7 degrees by performing a lateral closed wedge distal femur osteotomy. This is another example of 8 degrees of varus. The correction was made using the same way of correction because the deformity was located into the distal femur and not into the proximal tibia. Now, the third scenario is when we have a varus of the distal femur and varus of the proximal tibia, and in this case we should make the correction of both the distal femur and the proximal tibia, as in this example with a bilateral important varus of the knee. So the double level osteotomy would be the best choice, as in this case. However, to do the double level high tibial, the double level osteotomy, it is really not easy to do it without the navigation. So for those who do this type of surgery, the navigation is really a very important tool. Now, this is a case that I have operated without a navigation. This was a very important varus bilateral. This was a very young patient, despite the fact that this patient had an advanced osteoarthritis. I decided, because it was around maybe 40 years of age, so I decided to do a double osteotomy. So, in this case, what I did was an overcorrection of the osteotomy in the distal femur. This is not very good, but because I don't have the navigation, so I ended with this a good alignment, but with a mild overcorrection in the distal femur. So, what is the technique that I am using since more than 25 years now for the open wedge high tibial osteotomy? The patient in a supine position with an abduction elevation of the opposite leg, and so this will allow the surgeon to be on the medial side of the knee to perform the osteotomy on the medial side. And we should check for the C-arm accessibility before the surgery on AP and on the lateral view, and so the surgeon, as I said, on the medial side of the knee, a midline incision, and then the incision should go should go deep and sharply to the medial aspect of the proximal tibia without any undermining or dissection. And then what I do is a sub-periostal elevation of the pes anserinus and the most distal fibers of the superficial MCL. And this is a very important trick when you do the high tibial osteotomy. You should make a disinsertion of the most distal fibers of the superficial MCL to allow the correction and to have a good long-term result. Then a Homer retractor is positioned at the posterior edge of the proximal tibia, and then I put manually a pen at the joint level with a C-arm control to be sure that this is the level of the joint. Bas? Ooh. So 3 to 4 centimeters. So distal I will go. So the osteotomy حطيتها أنا التايمر بس مش عم طلع فيه. The osteotomy is completed with the osteotome. Then we use a rigid steel wedge, and the fixation is with a locking plate. What is very important is to observe this. The opening is very posterior. Anteriorly, we do not perform any opening, and the lateral side should always be respected without breaching, and we should always undersize the epiphyseal screws in order not to make any injury to the popliteal artery. Now, what about the filling of the gap with a supporting material? It is very controversial in the literature. However, it may contribute to reduce the blood loss, increase the mechanical stability, and increase the bone healing. Some authors suggested that filling of the gap is not necessary when we do an osteotomy, when we do an opening of less than 12 millimeter. However, based on more than 500 osteotomies, the same author Stobley stated that with the use of the LCP, it's not really to use a bone graft, even if we open for about 2 centimeters. These are some examples of my patients, and you can see with 18 millimeter, I didn't use any bone graft. I will go very quickly. The results, this is the most important. These are the complications, as you know: the overcorrection, the fracture of the plateau, the injury of the MCL, change of the slope and the patellar height. The most frequent complication is the irritation of the skin by the implant, since the plate is very superficial. Now, the good long-term results are related to the correct selection as recommended by the SSOS, a precise preoperative planning. This is very important, an adequate surgical technique, and a good fixation and early rehabilitation. So you can see that for some authors reported a conversion to total knee in only 24% at 16 years of follow-up. Long survivorship, this is an example. At 18 years with a good preservation. These are the factors of the survivorship: a good alignment, an overcorrection of around 5 degrees, or osteoarthritis of grade 1 and 2, age 50 to 55, BMI less than 25 to 30. So the deterioration occurs only after 15 to 20 years. In conclusion, open wedge high tibial osteotomy is a good option for the medial compartment osteoarthritis and active a patient. It may postpone the replacement for 1 to 2 decades. Good patient selection and use of the locking plates contribute to improve long-term results. The best results are obtained in young patients with low BMI, with a tibial bone varus angle more than 3 to 5 degrees, and in early osteoarthritis. Thank you. Sorry for.
شكرا دكتور علي.
حضرة الرئيس، إذا في سؤال قبل، لأنه مضطرين أنا والدكتور محمد.
إذا حد عنده سؤالين، إذا حد عنده سؤالين بس ممكن تفضل دكتور أحمد.
محاضرة رائعة جدا، موضوع مهم جدا. عندي سؤالين.
نعم.
بعرف انك تعمل دبل استيتوم، بس ما بتاخذ الباي بليتس.
لا.
لأنه الباي بليتس بنحل لك مشكلة.
I know, because The patellar height, most of them reported in the literature were with the closing wedge tibial osteotomy مع شوية immobilization in the post-op. واحد. اثنين, when you do the osteotomy very posterior, you don't change the slope, and if you start the rehabilitation the next day, there is some decrease in the patellar height, but around 15 لأنه أنا ما عندي وقت أحكي عن كل شيء, around 15% of the length of the patellar يعني ligament, يعني 15% بس من اللينث منه, وهذا يعني ما بيأثر كثير على على الفانكشن. يس أنا حكيت شوي. لا اقول لك شغلي, لما بتساوي الاوستيوتومي فيري بوستيريور ما بتغير السلوب, لانه اذا فتحت الاوستيوتومي قدام ممكن تزيد السلوب, وساعتها بتزيد مشاكل الاي سي ال اللي عم تحكي عنه دكتور احمد. مش هيك قصدك انت؟ صحيح. فيري جود.
دكتور سؤال ثاني تفضل.
No. In the open wedge, you don't need to cut the fibula. In the closed wedge, you need to do an osteotomy. This is one of the advantages of the open wedge. But بما إنه معنا وقت كتير حتى نحكي بالتفاصيل, this is one of the advantages of the open wedge.
بس ما بظن إنه هي بتشكل يعني عائق زيادة أو tension زيادة على.
No. In the open wedge, you don't need. In the closed wedge, you cannot close the lateral. لما الناس اللي كانوا يعملوا, أنا أول ما بلشت كنت أعمل الكلوز ويدج, بعدين الموضة تغيرت ورحنا على الأوبن ويدج. بالكلوز ويدج you need to cut the fibula. The advantage of the open wedge that you can change the correction during the surgery. If you correct the alignment and you feel it's not يعني enough, بدك تزيد أو بدك تخففها, you can do it. بعدين بتسوي the cut وحدي. بالكلوز wedge you do two cuts على التيبيا, and you cut also the fibula, and you have some يعني complications up to 20% of the lateral fibular يعني paralysis, lateral compartment. يعني this is a completely يعني different thing.
دكتور غسان, في ميكروفون للدكتور غسان للتعريف بالدكتور ميشيل.
شكرا دكتور علي.
اوكي شكرا.
زملاء الأحباء.